Welcome, everybody, and I'm glad you could join us today. On behalf of React 19 and the vaccine injured, we would like to welcome Dr. Lucinda Bateman, who will speak about myalgic encephalomyelitis, chronic fatigue syndrome, long COVID, and associated comorbid conditions. Dr. Bateman attended Johns Hopkins School of Medicine and completed her internal medicine residency at the University of Utah. She practiced as a general internist in Salt Lake City for 10 years. During that period, she recognized the need for advances in diagnosis and treatment of multi-symptom chronic illnesses like chronic fatigue syndrome and fibromyalgia. In 2015, she left private practice and formed the Bateman Horn Center, a nonprofit organization with a mission to improve the lives of people with fibromyalgia and MECFS through clinical care, education, and research. She has a passion for advancing the knowledge and skill of medical providers to improve the lives of underserved patients. Since 2002, she has served as principal investigator on more than 40 clinical trials. More recently, her research focus has been on MECFS and long COVID. She has collaborated with researchers from the University of Utah, Columbia, Harvard, Nova, Southeastern, Stanford, Jackson Laboratory, the National Institutes of Health, and the Centers for Disease Control and Prevention. Please welcome Dr. Bateman.
Thank you very much. It's a pleasure to be here. Let me see if I can get my screen sharing. It looks like it says host disabled participant screen sharing.
Oh, that would be useful, wouldn't it? Okay. Sure, let's see. Allow part, okay. Does it work now?
Yes.
Great.
Okay. Well, it's a pleasure to be here. I want to say I was talking to my sister on the phone this morning saying that I was really not sure how I could meet the standard of what you need to hear and what you want to hear. Because I'm not really a vaccine injury expert. And then I said to her, you know, though, what people need is validation. They need to feel heard and they need to feel like they're taken seriously. And that's what I've been doing my whole career. I will tell you, I was an expert witness on one case of vaccine injury that led to a case of MECFS. So I did sit alongside some very good experts. So I decided to call my talk Chronic Immune Illness Patterns After Immune Insult, because that's a better way to be inclusive and maybe we can, needs to put their camera on mute. There we go. I don't mind competing, but I want you to be able to hear me. So what I've decided I will do is go through and talk to you about what we've learned in the study of MECFS and long COVID and how it might relate to people with the kind of COVID vaccine injury that some of you have been experiencing. And just as a little background, I don't have to say much about this because you just heard it in the introduction, but our main focus right now as a nonprofit is really to improve the lives of people with MECFS, fibro, and post-viral syndromes, any of the comorbid conditions where we can use clinical care research and education in our multiple pronged approach. I think it's worth talking to you about what MECFS is, because it's probably the least understood of all those things that we're doing, maybe to the layperson. I think you're probably more informed than the average, but myalgic encephalomyelitis chronic fatigue syndrome is the whole word, and we shorten it to MECFS. And it's a chronic debilitating multi-system illness that is characterized by central and peripheral nervous system impairment, immune system dysfunction, and impaired energy metabolism, cellular metabolism. The cause is not really understood in a detailed way, but we know symptoms may be triggered by an infection, which leads to a post-viral or post-infection syndrome. However, and I will mention, there are other triggers that have been associated with onset of MECFS, including immunization, as you can see here. And I will say that sometimes it's a complex set of risk factors together when people get sick. They may have an infection, they may go in the hospital, they may have anesthesia and get antibiotics and get immunized. And when they come out the other end, it's a little bit hard to tell, right? What the factors were that led to their chronic illness. We know for sure, though, that from some studies that pathogens can lead to MECFS from research, and that is pretty strong, including Epstein-Barr virus, other herpes viruses, parvo, B19, West Nile virus, a whole category of viruses called enteroviruses, coronaviruses, including SARS-CoV-2, and some non-viral pathogens can lead to post-infection syndrome. But people who meet criteria for MECFS share the same core symptoms. And then they have a lot of differences of heterogeneity that may have to do with the type of a trigger, the systems that get affected, how long they've been sick, their disease duration, and development of comorbid conditions. And I'm going to talk a little more about what I mean by comorbid conditions later in the talk. But the important thing is by the time the diagnosis is made of MECFS, there's generally no definitive evidence left of what the trigger was. And that is the sad thing in people with MECFS. It's often 1, 2, 3, or even years or even longer before they get a diagnosis. So the COVID pandemic is giving us an opportunity to look at the early stages of illness with a much closer eye and much more tracking, simply because there's so many more people sick and we're testing everybody. So we're looking at a post-viral syndrome with long COVID in the early stages of disease, but keep in mind that that may, not all those people or all those symptoms may be remaining in the few people who remain sick for a long period of time. So I'll tell you how we diagnose MECFS. These are the Institute of Medicine 2015 clinical diagnostic criteria. Now remember, there's not really a test, right? So this constellation of symptoms that are of moderate to severe intensity and present at least 50% of the time have to all be there together. And that is impairment of function. And it needs to have gone on for 6 months before this label is given definitively. The patients have post-exertional malaise, that's illness relapse or worsening symptoms from trying to do activities. They have disordered, unrefreshing sleep, and then need to have at least one of the following: cognitive impairment or orthostatic intolerance. Those all have to be together in the patient, and it has to be moderate to severe and present 50% of the time. So you can see that not everyone with long COVID, for example, fits these criteria. That doesn't mean they don't have a post-viral syndrome. But to qualify for a diagnosis of MECFS, you need to meet these criteria. And that doesn't mean those are the only symptoms. Those are the core criteria that are common based on research to all people who present with this illness that we call MECFS. But we know that many people have chronic pain issues, immune and inflammatory manifestations, infection manifestations, and neuroendocrine manifestations, which we won't go into detail about. This creates the heterogeneity depending on how many other features of illness are with those core features. And MECFS, really the thing that of those criteria, all those criteria help distinguish this illness. But the two up front are the impairment or debilitation that occurs and the development of post-exertional malaise or illness escalation from doing activity. And PEM is worsened by activity or stressors, and these can be physical, cognitive, sensory, emotional, or even simply being upright can be a stressor that triggers illness worsening. And it's important to emphasize that MECFS occurs on a severity spectrum. And some people are walking, talking people who meet these criteria with mild impairment, but difficulty maintaining a normal schedule of work, school, or family, and very low tolerance for exercise, to the other end of the spectrum, where they may be bedridden, barely able to speak or move or tolerate any sensory input. So it's important to know that range exists, and not all patients can move through these phases. So a diagnosis of MECFS may, I know some people get very frightened about the idea that their symptoms meet criteria, but there is a spectrum, and there are different cycles and severities of illness, even in a given individual. As I said, there are no specific diagnostic tests. The important thing is, in recent years, we used to think there were no tests and nothing could be done for MECFS. But as our knowledge has progressed, we realize there's an increasing awareness of comorbid conditions and that contribute to the presenting symptoms. So I'm going to just try to help you understand what I mean by a comorbid condition. And a comorbid condition, think of it as a diagnosis that can stand alone, with or without MECFS, like POTS, for example, but seems to commonly occur in people with MECFS. And if those illnesses are comorbid with MECFS, that condition may be much more difficult to treat than when it stands alone. And POTS is a good example. That's why it's important to know if people meet MECFS criteria, not just if they meet the criteria for a comorbid condition. So over the past few years, we've come to recognize, both in MECFS and in long COVID patients, these are some labels or comorbidities of things that we have begun to identify. Now, remember, these are things that can stand alone as an illness, or they occur in combination with the MECFS, probably and as part of the MECFS physiology. We don't know for sure what leads to what. And sometimes these comorbidities develop over time. They're not all present right in the beginning. Now, the first three I'm going to talk about in our talk today: small fiber polyneuropathies, orthostatic intolerance syndromes, and we're going to talk about mast cell activation. But I know you've probably been hearing in the news about other kinds of comorbidities with long COVID, including viral reactivation, particularly herpes viruses and Epstein-Barr virus, or EBV. There are autoantibodies and autoimmune conditions that tend to spring up because of the immune activation, we think, or the immune dysfunction. And then pain amplification and sensory or central sensitivity that can develop in patients, as well as chronic sleep disorders. And you can see they get a little more common, and there is a very long list. The reason it's important to know is because we don't have a magic bullet treatment for MECFS, you can grab onto these comorbid conditions and work on them and improve aspects of the patient's presentation. So first, we're going to talk about small fiber neuropathy, or sometimes called small fiber polyneuropathy. The term small fiber poly or many neuropathy implies that it's very widespread. It can be patchy too. So small nerve fibers, also called C fibers, are tiny, bare, that means they're unmyelinated, sensory nerves and autonomic nerves. The two main places these small fibers are all the nerves that help with sensation, bringing in signals, pain, pressure, temperature, light, sound, the nerves that bring signaling into your brain, and then your autonomic nervous system nerves that implement nerve signaling to what we call smooth muscle. And that's involuntary muscles that constrict and dilate blood vessels, or contract and relax your gut, or contract and relax your bladder. Your whole body has organs that are signaled by the autonomic nervous system. So when someone presents with sensory symptoms and autonomic nervous system symptoms, that's a big red flag that a small fiber neuropathy may have occurred. Now, sometimes we just think of a small fiber neuropathy in terms of pain. And there have been studies to show that fibromyalgia, for example, people with fibromyalgia, especially young people with fibromyalgia, may be all due to small fiber neuropathy. And it can give you symptoms like pain, tingling, pins and needles, burning. It's nerve pain, transient electric shock pain. Really strange pains can come from small fiber neuropathy. And some of it is a pain that worsens when you're at rest, when you're trying to sleep or when you lie down at night. But aside from pain, your autonomic nervous system and these sensory symptoms can cause numerous symptoms in your body: dry eyes, dry mouth, orthostatic intolerance. We'll talk more about that. Sweating, GI symptoms, and urinary symptoms. But the frustrating thing is, physical exam, even a standard neurologic exam, might miss the findings on physical exam from a small fiber neuropathy. And the standard tests like EMG, electromyogram, and nerve conduction tests and MRIs, those don't show those little tiny nerves either. So the skin, in order to really know if someone has a small fiber neuropathy, you need to do a skin biopsy. And that's a little bit out of the ordinary, not done by ordinary physicians as much. And not only that, it really is a little bit difficult to interpret and needs to go to a high quality lab with appropriate expertise. But in that setting, and this might be kind of hard to see, but if you can see, this is a electron micrograph of a skin biopsy. All these little teeny hair-like nerve fibers, this is normal over here. And you can see on this side, there is a big absence of those tiny nerve fibers, which would be considered a small fiber neuropathy. So we think small fiber neuropathies are underdiagnosed due to lack of objective markers and quite variable presentation. It's not as not length dependent like a peripheral neuropathy, where just the longest nerves get damaged, like in diabetes, and your hands and feet get the neuropathy. And it's also confusing because there are many causes of nerve damage for a small fiber neuropathy. People could be genetically predisposed, viral infections, inflammation, immune changes, autoimmune damage, toxic exposures. All kinds of things can cause even diabetes itself. I consider that kind of a toxic exposure, the metabolism and the abnormalities during diabetes. So finding out you have a peripheral neuropathy doesn't always tell you why it happened and what the actual trigger was. So this just give you a quick example. This was a person that I had a remote visit with who sought me out to get some help. And she was a 61-year-old physician who was busy. I did not mean to change that. Let me go back. She's busy. It's notable that when she was 20, she got really severe mono, EBV mono, so bad it gave her hepatitis as well. And it took her 2 years to recover. So she had a post-viral syndrome that probably met criteria for MECFS, or at least a post-viral syndrome back when she was 20. Then she got completely better. Then in 2019, she was probably 60 at that time. She was busy on the hospital ward. She got a cold and sinus infection. She kept pushing. She got antibiotics. But as the weeks progressed, she got progressively less able to do her work due to brain fog, fatigue, and cognitive impairment. And she tried to take some time off, but she never was able to go back to work. And it got worse: headaches, trouble focusing her eyes. By November, she couldn't walk outside of her home. She was homebound. She saw internists and rheumatologists. And then she got another cold, and she was so short of breath and sick, they put her in the hospital for 5 days. She saw every kind of specialist, well, not every kind, but nobody could figure out what was wrong with her. But she did see cardiologists, pulmonary, neurology, infectious disease, and rheumatology, and none of them could figure out what was wrong with her. And they were highly motivated. She was a doctor. And so she probably got, a little bit of special attention. So she met with me and remotely, and I was pretty sure she met MECFS criteria. She had typical scores. We did a questionnaire for orthostatic intolerance. That's problems like POTS. And I sent her instructions on how to do orthostatic testing. We're going to talk about the 10-minute Nasoline test. And I recommended that she get a skin biopsy for small fiber neuropathy. So she did both of those things. These are the vital signs she sent me. So when she's lying down, her blood pressure is 122/75 and her heart rate was 85. And as soon as she stood up, you can see her heart rate went right up to 100, 126, 132, kind of peaked at 140 right there, and then kind of started to go down. And her blood pressure dropped from just look at the systolic, or the top number, dropped from 122 to 108, 98, then it came up, and then it went down, and then it kind of settled around 102, and it was hard to hear, but you can see that it dropped 20 points. So that increase in heart rate from 85 to 140 is 55 beats per minute increase. That qualifies for a diagnosis of POTS. But she has more than POTS because she also dropped her blood pressure. She's got a very severe problem with her autonomic nervous system. And when she got her small fiber biopsy, her skin biopsy back, they confirmed that she had a small fiber polyneuropathy. So what is this term orthostatic intolerance? It's a general term, and it means that you develop symptoms in upright posture that are relieved or partially relieved by reclining. So for it to be an orthostatic intolerance, it has to be in that kind of a situation. And those symptoms come from reduced blood flow to your brain and reduced blood flow to parts of your body. So it can give you these cognitive lightheadedness, fainting, cognitive disoriented, visual changes, unusual neurologic symptoms, and exhaustion. And it can give you palpitations, nausea, abdominal and chest discomfort, cold hands and feet, feeling really anxious, short of breath, sweating, tremor. I mean, it just feels awful to have orthostatic intolerance. And if many people have enough orthostatic intolerance that they don't, or it's so chronic that every time they stand up, they get symptoms, but they never faint. So they don't think to investigate and see if they're having a problem with their blood pressure and heart rate. And it gets worse when you're hot, dehydrated, if you've been sitting or standing too long, if you get deconditioned and weak and on certain medications, and can certainly make it very difficult to exercise. Now, there are some specific terms that are used for your reference, specific syndromes of orthostatic intolerance. Orthostatic hypotension means your blood pressure drops, and if it's the systolic, it has to drop at least 20, or the diastolic, that's the bottom number, at least 10. You've heard of the term POTS, postural orthostatic tachycardia. For adults, your heart rate has to go up more than 30 beats a minute, unless you're in your teens or 20s or early 20s. I guess this is 12 to 19. It has to go up at least 40 points. And then if you faint, it's called neurally mediated hypotension, or vasovagal fainting, or neurocardiogenic fainting. That's the one that cardiologists and neurologists are the most familiar with. So how would you know if you had orthostatic intolerance? Well, to me, the most simple way, and the way we screen for it in our patients, is simply ask people what their hours of upright activity are. That means how many hours during a 24-hour period are your feet on the floor? So that includes sitting. So standing, walking, and sitting if your feet are on the floor. And if you think about it, and I can tell you this is true from our data in clinic, most people have 14 to 17 hours of upright activity. Think about 14, that means 10 hours, you're lying down, so 8 hours of sleep, and then we'll give you a little bit more during the day to put your feet up or watch TV or something. And then people with chronic illness, it goes down, even fibromyalgia, because they have to sit down and rest, but they can rest in a seated position. But people with MECFS have 0 to 8 hours of upright activity tolerance, and many of our patients have some kind of orthostatic intolerance. So this is the test we do, and that's because we don't have tilt table equipment. We're not cardiologists, and I'm trying to empower patients and primary care providers and all kinds of physicians to be able to do orthostatic testing. So this requires lying down for 15 minutes before the test to measure your vitals. Then you stand up quietly, leaning against the wall, and start to measure your heart rate and blood pressure. So the top number is the systolic, the diastolic, and the pulse is your heart rate. A couple times lying down, and then every minute. Or if it's hard, you can do it every 2 minutes. And you want to stay up the whole 10 minutes unless you can't do it safely. So here's one man in our clinic, 45, came in with long COVID, didn't know why he was so sick, why he couldn't function, why he couldn't go to work. We just had him do the Nasoline test in clinic. Seated, his blood pressure was 120/80, and his heart rate was 82. Perfect, normal heart rate and blood pressure. When we laid him down, I'm just going to show you his heart rate, and had him rest and let the dust settle. His heart rate came down to 65. As soon as we began the standing portion of the test, he became symptomatic. His heart rate went up, and at 8 minutes, his heart rate was 138. So that's a big jump. That is a jump of 73 beats per minute. And he could not make it. He was going to pass out. So we stopped the test. He meets criteria for POTS. And you can see he didn't have a whole bunch of change in his blood pressure, except the diastolic crept up a little bit. So what do you do if you have POTS? Well, there are lots of things. Or I'm going to just say lump orthostatic intolerance. What do you do if you have orthostatic intolerance? Well, you avoid the triggers, getting overheated, dehydrated, too much standing in place, too much time feet down. Also, if you have too much bed rest, you're also going to get weak and deconditioned. And then you want to understand other triggers. And I'm not going to spend a lot of time on interventions. There are many resources. You can come to our resources at Bateman Horn Center for details, but you want to increase the volume in your blood vessels. You want to compress. And there are medications to control your vascular tone and your heart rate that doctors know about. And you want to strengthen the muscles in your legs and in your abdomen, because these muscles add squeeze, and they actually have a little pumping action, which is why sometimes people want to sway back and forth on their when they're standing in place if they have orthostatic intolerance. All right, our last topic here, I just want to talk quickly, but what is mast cell activation syndrome? Mast cell activation is an illness of repeated allergic reactions in several body systems. And mast cells are present throughout much of our body. It creates a lot of symptoms. The exact cause is not known, but may reflect underlying chronic inflammation. So when there are other processes going on in other arms of the immune system, it may activate the mast cells, which are also part of that. So this is a little more detail. They are found in tissues all over your body, especially under the skin, near blood vessels and lymph vessels, and lining your gut, in nerves and the lungs. So when these cells get activated, they release their inflammatory chemicals, which we call cytokines, including histamine and leukotriene. It creates this cascade of problems that creates more inflammation in those areas. And it can also alert mast cells throughout the rest of your body. So the criteria, the clinical criteria for making a diagnosis of mast cell activation is you need to have symptoms consistent with this in 2 or more organ systems. So symptoms involving your skin, your GI tract, your cardiovascular system, your respiratory system. This is the lower and the upper respiratory system. So if you think you have symptoms, and some people have symptoms in all those systems when they have severe mast cell activation. So step number one is having symptoms in more than one place, not just your skin alone or not just asthma alone. Then these symptoms should improve with the basic treatment that involves calming mast cells, H1 and H2 histamine receptor blockers, anti-leukotriene medications, and mast cell stabilizers. And this slide has a little bit more detail. And in addition, patients often follow a low histamine diet. So there's a little more detail about mast cell stabilizers here, and also a little more advanced medication that impact IgE, which is one of the antibodies that mediates anaphylaxis. So the third thing to make a diagnosis of mast cell activation is to have some evidence, if possible, of an elevated marker that the mast cells are activated. And this, again, this is kind of for your reference, but the doctors can look for elevated tryptase and histamine, and then these other downstream byproducts of these release in a urine sample. You can also get a tissue biopsy of involved tissues and stain it for excess mast cells. But your mast cells may not be too many more in number, like they are in the genetic version of mast cell disorder. They're just more sensitive and overactive. But that's good, because sometimes that's a reversible and treatable problem. There are many triggers of mast cell activation: heat and cold, stress, exercise, getting overtired, things you ingest, food or beverages, drugs that you also ingest, things you inhale, things that sting you, infections, mechanical irritation, even drawing on the skin. So that's dermatographism, is kind of, running your fingernail on the skin, and it creates a swelling that shows that you can even write on your skin and leave a trail of swelling. And when I was young, I was told I was allergic to the sun, because whenever I went out in the sun, I broke out in hives. So for a period as a teenager, I must have had some kind of an allergic reaction that could be seen in mast cell activation. So I wanted to finish my talk. That was quick. You can reference our slides, come back and look at them, or you can take any individual topic and do some more research. But I wanted to just let you know that we see these syndromes in post-viral syndromes, in long COVID, and I'm pretty sure that if a vaccine sets up a neuroimmune or an immune response, that these very same things could develop. So what do we do to treat the patients that come to our clinic? I'm just going to share with you, this is a very big umbrella. I call it the time-tested general treatment approach for all of the syndromes that come to our clinic. The first is to identify and treat all medical conditions. So, if you're hypothyroid, you need to treat it. If you've got celiac disease or low vitamin D or whatever it is. So the doctors do a good workup to look for underlying driving factors like diabetes, for example. And then to look at these a little more poorly understood comorbid conditions that, like the ones we've just discussed, that maybe doctors aren't as familiar with. Next is you want to learn how to pace your activity to prevent and reduce the severity and duration of post-exertional malaise. In other words, don't try to push through your symptoms. Let your symptoms guide you to kind of downsize your activity and your stress, instead of having big push crash phenomenon and a pattern that makes you sicker and sicker. And then you want to just generally address the major aspects of illness. And this is just good chronic illness counseling. One is you want to reduce the mental health component, your emotional response. You got to adapt. and go through the stages of grief, and don't let it scare you. Get as much as you can to get your mental health back to a more resilient place, because it triggers your autonomic nervous system and immune changes and hormonal changes that can aggravate the illness. If orthostatic intolerance is present, just try to support it. Just being sick can give you orthostatic intolerance. Just being in bed too long can give you orthostatic intolerance. So you can start with the basics and give yourself good support, and it can be escalated if the symptoms are more severe. If pain is a stressor, severe pain, you need to address pain. You don't have to make all pain go away, but if pain's keeping you awake at night and making you anxious and making you exhausted, that pain, those pains need to be addressed. And I can't say enough about sleep. Lots of important things happen during sleep. Your brain replaces neurotransmitters, your immune system restores itself. There's so many activities that happen in your brain during sleep that just being sure that you get enough sleep and then doing everything possible to push and nudge your sleep to a more restorative place. And sometimes that's incredibly challenging. Some of it is self-induced, and some of sleep disruption is an intrinsic part of these illnesses, driving changes in sleep. And then lastly, you do want to remain as fit as you can, but it has to be compatible with your illness manifestations. It can't be triggering post-exertional malaise. So pacing trumps fitness. But if you can do things, learn to do what you can to maintain some of your muscle strength, your flexibility, and whatever amount of activity you can tolerate. But you have to learn how to do it along those lines. So there are just a few resources I'll throw up here. There are many, many resources. There is this is just one mast cell activation reference. There's a dysautonomia international reference. We have great videos on YouTube. Just go to YouTube and put Bateman Horn Center in, and we have educational videos that can help you, as well as many, many rich resources on our website. So I'm going to stop sharing, and my understanding is that we're going to leave some time for questions.
Thank you very much, Dr. Bateman. That was really informative. And the thing that just hits me in the face listening to your talk is that we as vaccine injured are just a carbon copy of these other syndromes. So there must be a lot of overlap immunologically, or we don't know yet why.
You know, I'd be interested in knowing, we can't do it in this setting, but and maybe you could do it in another setting, at how many people who are vaccine injured have had mono, well-documented mono sometime early in the course of their life. That would be a simple question. It should be noted, though, that 90% of adults have been exposed to Epstein-Barr virus. So mono is when the illness is severe enough that it gets medical attention and you go and get it tested. So everybody's probably had it, but that may not be the factor. It may be that your body didn't handle EBV in the first place, right? And you had a harder course or a longer course. And then when you got sick, or in the pandemic, or when you got that vaccine trigger, right, it created some kind of interaction. But the bottom line is we don't know yet. We just don't know yet what all the processes are. We don't know for long COVID, and we don't know for MECFS either. So what we need to look is for the common denominators.
One thing that some of us have been tested for our T cell ratios and flow cytometry, and a lot of us have been found to have low suppressor T cell levels, which will make you prone to reactivation of viral illnesses. And I know some in our group have been found to have EBV reactivation. So, there might be something to that. Anyway, have the T cells been looked at in MECFS?
Yeah, there are actually a lot of studies in MECFS. And if you want to see a good summary, go to the go to Bateman Horn Center and look at we have a handout that you can take to urgent care or the emergency room. If you want, if you're going there for another condition and you want to hand the doctor something that explains your illness. And that handout has got a lot of information about the underlying processes in a really good summary of what some of the good studies are supporting each of the aspects of MECFS.
And before I go,
Talia just put it in the chat for you if you want to link.
great. That'll be so helpful, because one of the problems, one of the biggest problems we've all faced is being validated by the medical community as this is a new disease, that no one has heard of. And unfortunately, the higher ups in medicine aren't talking about it. So, the doctors aren't educated yet about it. So if we had things to hand to our doctor to look at, it might help to get moving forward a little faster.
I just want to say another quick thing, and that is we're a small organization, relatively speaking. We have 2 physicians and 3 other clinicians, nurse practitioners and PAs. And we have a pretty full practice, and we all have multiple responsibilities. And I learned a long time ago, I was never going to be able to be the one to see every patient, because the numbers are just overwhelming. So at Bateman Horn Center, we've put a lot of effort into outward education, resources for patients, education for other physicians. And I'm mainly saying that because a lot of times after I give a talk, understandably, patients are like, how can we come to your clinic, right? And I'll just say we can't handle the numbers that need to come to our clinic, and we're doing the best we can, but we're trying to fill the gaps.
Do you see patients outside of Utah?
It varies. We're going to, during the pandemic, that really changed everything, right? And we do. The second thing is we've learned that really sick people don't do very well if they travel across the country and come to a visit. And right now we're very limited, and we're about to enter a period where we're going to see only patients from Utah, but mostly because we want to enroll patients with early onset MECFS for direct comparison to what's happening with long COVID. But because we're a research clinic, our focus changes. And so our priorities are in a constant state of flux. And so you just have to go to the website and see what we're doing and when we're doing it.
Okay. I guess I have a couple more questions, and anyone else, please send your questions through the chat. Some of us are being studied immunologically to look for autoantibodies. I think there are some studies beginning to look at it more in depth, but we've been sending our blood to Germany and to Washington University that has a neuromuscular lab that looks at autoantibodies. Has that been looked at in MECFS?
Yes, but not so much in the research. What we see is clinically, right? We see people clinically come in with celiac disease and autoimmune thyroid disease and other kinds of things we know are autoimmune, but they're not the same really as what we see in a rheumatology clinic. But we don't have very good systematic research in MECFS about autoimmunity. But everything about MECFS looks like, smells like an autoimmune disease. And it has all the features of an autoimmune disease. So, certainly we're seeing autoantibodies in long COVID. One of the problems with long COVID is we haven't had a long enough time to observe the evolution of illness. And there definitely is an evolution of these kind of illnesses as the immune system morphs and changes down the road. But I would like to put in a plug for participating in research. One of the ways that we've been able to make tremendous progress in the last few years in MECFS is people, just donating them, themselves to research. learn from me, learn from me. And we have patients we have about 150 patients in my clinic who've repeatedly, signed up in different research protocols. And there just aren't very many clinics that can round up 150 patients. And you get a little flavor of that when you're the post-vaccine injury, but long COVID, we're not gonna have any problem rounding up long COVID patients because they're everywhere. So it's really a matter of making yourself available and volunteering for as much research as you can so we can move along more quickly. Recruitment of patients is one of the things that slows research the most. It's just not having enough patients.
I think there's a plethora of volunteers in these groups. The problem is the research really hasn't begun. There isn't funding, so we're all willing and ready to do whatever. We send our blood wherever we hear they
That's
might
awesome.
be studying it, and yeah. And then just as a corollary to the autoimmunity, some of us who've been sicker for a longer period of time have been treated with various treatments like plasmapheresis and IVIG and immunosuppressant drugs. And there's been a fair amount of improvement with those modalities. Do you see that as well with the MECFS patients, or is that used in that?
I'll say, as a long-term veteran in the field, I used to be in a position where I wanted to try everything in everyone. But over time, I've become much more focused on large clinical trials because it's easy. You can't always tell what's working because people with these illnesses can spontaneously recover. I think lots of people are going to improve over time, and all of those have potential as therapies, but we need good, placebo-controlled or some kind of controlled clinical trials before we recommend it globally. That said, I'm not against people trying things if they can find access to it, but it may not be generalizable, right, to the whole population of patients.
Right.
Do you want me to take there's a couple of questions in here.
Yeah, go ahead. I was going to read them, but if you see them.
So one is there always pain with small fiber neuropathy? But definitely not. We've kind of focused on the pain in the past. Maybe that's why we've missed all the other stuff. So it can be patchy and it doesn't always create pain. And corneal confocal microscopy is coming along as another supportive diagnostic test for small fiber neuropathy. So that's exciting. And then the other question is, how important is it to get an MECFS diagnosis? I have my own feelings about this. I'm biased. I think it is important because we need to educate doctors about what it is and to be able to recognize it and to make a correct diagnosis. But it doesn't matter what diagnosis you get if you get an understanding physician who approaches and treats your symptoms. And we can't all agree. It's like the patient case I gave you. The original case, I stole that case from another talk, but in the original talk, I said, does this patient have MECFS or small fiber neuropathy? Well, she has MECFS. She meets MECFS criteria, and she definitely meets criteria for POTS, and she definitely has a small fiber neuropathy. So if her doctors, and they didn't, they actually said the MECFS was a misdiagnosis. Her doctors diagnosed her with small fiber neuropathy and her dysautonomia, and she got care. And so I wouldn't be too invested in the diagnosis.
Okay.
Quick question about low-dose naltrexone, or LDN. LDN is a very effective treatment for fibromyalgia. So the pretty typically defined. When I say pretty effective, I mean effective like FDA-approved drugs that have been proven to work, but aren't effective for everybody. And there's a spectrum of how well it's tolerated and how well it works. The jury's out, I think, on how LDN helps other inflammatory and neuroinflammatory illnesses. And it's safe and not very expensive. And it takes a while to work. So anybody who wants to try it in our clinic, we go ahead and let them try LDN. But again, this is another example, as we need larger studies to be able to understand where it works the best. I'll go back to letting you pick.
Oh, okay. Let's see. How important is it to get an MECFS diagnosis? My doctors are hesitant to give me the diagnosis, although I fit the criteria.
Yeah, so I don't think it's very important. I think it's okay, as long as they can diagnose your comorbid conditions. The main reason, in my opinion, to diagnose MECFS is that doctors don't understand about impaired function and post-exertional malaise and the energy metabolism problems. For example, sometimes people with POTS are told to given a vigorous exercise program to try to rehab their POTS. And I've seen people who also met criteria for MECFS really worsen and become much more ill from trying to carry out the exercise instructions. So that is a reason, but you can do that on your own. There aren't enough MECFS educated doctors out there. We're working on that. It's getting better. But you can educate your own doctor too.
We're doing a lot of that, I think. Let's see. As a lifelong MCAS human who never had COVID but is vaccine resistant after, what is the question? After vaccine have been, let's see, who, I don't understand the question.
I think it might mean that
Not reading.
after the vaccine now meets criteria for MECFS. So this is an example of MCAS is a standalone diagnosis. You can have MCAS without having MECFS, but you can go on to develop worsening function and getting to the point where you meet those criteria. That's MECFS. So the diagnosis of MECFS is a set of symptoms and function in a measured way. It doesn't imply cause. So if you have impaired function, post-exertional malaise, and unrefreshing sleep and cognitive impairment, present, that's moderate to severe and present more than 50% of the time, or orthostatic intolerance, that's how we define MECFS.
Another question is, if a patient fails even beginning the CHOP exercise program for POTS, at what point should they try it again? Or would something else be more appropriate for these patients?
I think it really needs to be individualized. So, and that's why you need to be educated. Everybody needs to self-educate. And that's, if you remember those treatment recommendations, you should do what you can do without triggering post-exertional malaise. So my guidelines for people is you can do whatever you can do in a day that you're completely recovered from the next day. You shouldn't be having, escalation or lingering symptoms or consequences of your exercise the following day. So you need to ratchet down the exercise intensity or duration or both so that you don't have any consequence from exercise. You should set that pace, not someone on the outside telling you. And it's another reason to get yourself emotionally stable so you're not scared, right? Not scared of trying things. You've got to learn to observe your body and intelligently implement these guidelines. That's easier said than done, right? But that's the goal, right? Those big general goals are the direction we work with people. Sometimes it takes up to a year when people come to really feel like we're getting a handle and helping them balance all those different areas of the treatment plan.
The next question is, a number of people on the Facebook page had no pre-existing health issues prior to the vaccine injury. No prior mono, no autoimmune diseases, no allergies. Is the picture different for us?
I don't think so. that's the picture of all the long COVID patients we've seen in our clinic, because we don't see patients who are hospitalized with COVID and have, bad consequences of COVID. We use a screening tool in our clinic. We only see people who were relatively healthy before they got long COVID, before they got COVID and long COVID. Some of them didn't even have very severe COVID at all. And the same is true with many, many MECFS patients. Before it hit, they were perfectly well, like my doctor, right? Example I gave. But everybody's different. And sometimes we see hints in the past, right, of mild allergies or, kind of a prolonged episode of mono that are, normal. But when you look back on it, you can start to see a path maybe and some hints of what might be going on.
There are major theories about microclots or endothelial dysfunction of the blood vessels being the cause of long COVID. There is treatment in Germany called HELP apheresis to remove microclots in long COVID with good success. They're trying to use this with MECFS with the same success too. What are your thoughts about this research and findings?
My thoughts are it's interesting, intriguing, hopeful, but early. A little bit early to know.
Yeah, just anecdotally, I correspond with a vaccine injured woman in Germany who just went through this treatment and has had very good success with her symptoms. And I know we have some other people who are thinking about going there for treatment. So
I think it's really interesting for sure.
Yeah.
Yeah, he's got to fix up everything.
Uh-oh.
There's my boys.
Stay mute, please.
Mute, please.
Go.
Is this possible? I was given 3 shots as an initial series, but didn't experience extreme fatigue until the 3rd shot over 3 months ago. Joint pain has markedly increased. So I guess the question is, can you develop a reaction after the booster, the 3rd booster shot, and not have had a reaction prior to that?
You definitely can. I mean, most allergic responses happen after a previous exposure. So if someone goes for their first shot and gets anaphylaxis, it's probably related to something in the vaccine that they've had prior exposure to and triggered anaphylaxis. So I think it's actually more likely that it'll happen after your body has had an abnormal immune response to something and then sees it again. And this is one reason why we've coached our patients, our MECFS patients, to get on a mast cell activation regimen before they go get their immunizations and their boosters, to kind of calm down whatever overactive mast cell response or allergic response might happen.
Okay, 2 or 3 more. A lot of us have seen a number of physicians, including functional medicine providers, who have recommended a plethora of supplements to help with symptoms. Have you found anything that has proven to be helpful across the board, or have any test recommendations or do you have any test recommendations that would more specifically correlate to a supplement?
So I'm just going to take a step back and say, over the many years I've been taking care of MECFS patients, my philosophy has changed. I used to try everything that I thought might add some little tiny iota of benefit. And then I've gotten more and more frustrated by, anecdotal stories and so many people not generally responding and getting better, that my own personal role has been pretty conservative now. And but I encourage people, because I don't think it's going to make a huge difference in the long run, most supplements. That said, there's some hypothetical support, right, for giving your body the things it needs that might be missing and might be broken. So I usually let my patients make their own decisions about supplements. I mean, I individually can talk to people, right, about some general supplements that might be helpful, but I caution people not to lose all their money, not to spend too much money, and not to overdose on supplements, right? And to try to pay attention to if you think they're helping you, because any substances you take in your body you could get a reaction to, or it could bother your stomach, or you could become allergic to. So you need to take responsibility for paying attention.
Another question, any suggestions to increase mitochondrial and cellular production and exchange of energy in these conditions? And the second part of the question is, what does the typical MECFS patient timeline look like as far as recovery?
So I will say that the suggestions about increasing mitochondrial and cellular production, we don't really have a good way to do that. And that's basically the rationale behind a lot of supplements, is to kind of provide those building blocks for mitochondrial function. And we'll see over time if that's going to be helpful. And the typical MECFS timeline, I will have to tell you, is like all over the map. There are people who are sick and gradually, super sick and gradually recover to about 90%. There are people who have steps of ups and downs. There are people who go along medium sick and then get super sick. I mean, it's all over the map. And we don't track how many people get better in the first 2 years because we don't have that research. So I think that probably lots of people who have the same onset gradually improve and get lost to follow-up. And we tend to follow the people who don't get better. So I tend to stay optimistic. When a patient comes, I always feel like we can add benefit and improve their chances, reduce their symptoms and improve their function, improve their chances of recovery. But we don't really know how to predict that.
Do you have time for a couple more? They keep coming.
Yeah, I do.
Are you okay? Okay.
If everybody's okay going a little longer.
Yeah.
I'm sure we'll have to cut it off sometime because I'm sure there are millions of questions.
Yeah, there are. And they're just, I'll limit it to 2 more. My EBV reactivated after the vaccine, but both my neurologist and primary care physician said that it would recover in time and did not suggest any antivirals. This is the same course of action for many in the online EBV support groups. Is it common to not prescribe any medication for reactivated viral illnesses?
Right. So with some herpes viruses, we're very aggressive about treating reactivation. So let me give you an example. If you develop shingles, which is reactivation of varicella zoster virus, you're going to, if you get into a doctor soon enough, you're going to be treated immediately to try to reduce long-term consequences. And that's in part because we have drugs effective for treating the varicella zoster. They have to be given at a pretty high dose, but they do work and they do change. And we have lots of research to support that it changes whether you get chronic pain, right, from shingles. Same with, let's say, genital herpes. We have learned we're very effective at treating herpes acutely and treating people long-term for reactivating herpes simplex for genital herpes. And we have really good drugs. Herpes simplex is very sensitive to our antiviral drugs. The problem with EBV, there are many. One is it's very difficult to prove someone has reactivated EBV. The antibodies titers suggest it, but don't prove it. You have to get viral load like we do in HIV. I mean, if people have antibodies to HIV, we know they have HIV, right? To know how active it is, you have to get PCR. But when 90% of people have antibodies to EBV, they become a little more difficult to rely on as proof of viral reactivation, even if they're high. And it's hard to get PCR positive EBV because it might not be in high level floating around the blood. The other problem is we don't have very good drugs for Epstein-Barr virus. Epstein-Barr virus is not very sensitive to the current drugs we have. So over time, there's been, a feeling in the medical community, even with acute mono, that it's going to run its course and that giving people antivirals isn't going to change the outcome. And that has been the way it's been. Even in antiviral drug trials in MECFS, we've been unable to prove that putting people on antiviral therapy really results in a change in the course of their illness. And that's a long discussion, but yeah, it's a thorny problem. But I'm hoping that as we learn more about EBV reactivation, because there's more interest in it now, right? More interest in it because of data suggesting that's happening in long COVID. And it's also, there've been a recent paper saying that EBV may be playing a role in multiple sclerosis, for example. And I know there's been an increased interest in developing a vaccine for EBV. And I would hope that there will be increased interest in development of antiviral drugs that are effective for EBV. So that's the hesitation, is it doesn't work very well, right? And we're not good at it. And so you got a range of doctors who will be super conservative and not step outside the lines of recommendations, and then doctors who are willing to try the antivirals, but it's hard to know if they're doing anything.
One last question, and then there have been a few comments about Ehlers-Danlos syndrome and the correlation with these illnesses. But before we do that, are there alternative diagnoses that could be confused with vaccine injury or MECFS? For example, breast implant illness, replacement joint infections, medical device infections, et cetera.
Oh, definitely, right? And it depends on how tight the temporal association, the timing association is. But things happen to people every day. And during a 2-year pandemic, for example, people still get Guillain-Barré, people still get, right, even before the pandemic. So, there are underlying diagnoses. That's why step 1 in the treatment plan, in the plan of attack, is to understand all other conditions and medical conditions and comorbid conditions the best possible. And that's not a one-time process. That's kind of an ongoing process, right? As you're treating and unfolding and taking another look and making sure that there isn't, but there are lots of illnesses we don't have good diagnostic tests for. For example, like breast implant illness. But there we have, again, what we need to look for, the common threads. And the common threads may be something that triggers an immune response, right? A chronic immune response, and then a cascade of problems happens after that.
There have been a few questions about Ehlers-Danlos, but I see Dr. Yellman is trying to get you home to dinner and answering them on the chat. So do you want to just say a word about EDS, the correlation with that?
Maybe I'll, since Braden's thinking about it, maybe I'll have him comment. He came on today to be support in case I got stuck on any questions. And so he could have done this whole lecture himself, but Braden, do you mind talking about EDS?
Yeah, so EDS is really thought to be an underlying risk factor for the development of MECFS, for the development of long COVID, and probably for the development of vaccine-induced injury as well. And it also is a risk factor for the development of many of the comorbidities we discussed today. Many with hypermobile EDS will have small fiber polyneuropathy, will have postural orthostatic tachycardia syndrome, they may have mast cell activation syndrome, or they may have none of those things. I can say even in my own life, I actually have hypermobile EDS myself, and I do have postural orthostatic tachycardia syndrome. And after I received my 3rd vaccine dose, my booster dose, I started having a little bit of hives, not a full-blown mast cell activation, but that's the first time I've ever had those symptoms in my life. So it's certainly a risk factor for those things, but it doesn't guarantee those illnesses. And I can say certainly I didn't have, vaccine injury beyond just some very mild hives. and I don't have MECFS. I do not have the primary pathognomonic feature of post-exertional malaise, and hopefully I never get it. But if I ever do start feeling ill, I think it's important to say that I need to respect my body's symptoms and understand that I have those risk factors, and make sure I take it easy and rest and don't push myself into something that might feel like post-exertional malaise. That kind of takes me into an answer to another question, which is what can we do, long term with MECFS to have a better outcome compared to a worse outcome? And at its core, everything we offer from a treatment perspective is really designed to help people avoid post-exertional malaise and get them more functional, being able to avoid post-exertional malaise, because the more repeated, more intense, more prolonged post-exertional malaise that one experiences, the more likely they are to have long-term worsened functional prognosis and consequences. And alternatively, while there's no guarantees, people that we do see have better courses or some improvement in symptoms tend to be people that can avoid post-exertional malaise for the most part. It will always happen to everybody at some point. People will slip up, and it's really hard to avoid sometimes. It can be a lot more involved for some people than others, but ultimately trying to reach a place where the extent of what you can do cognitively, physically, emotionally, and trying to avoid that crash is the long game for having a better functional outcome in the end.
I have one last question. Do you, in your clinic, do virtual visits with out-of-state patients?
We have at times in the past, but we're not able to do that right now. Just the schedule is just too crowded, and it's much needed, I understand, but we're not able to do it right now.
And to be fair, we've tried to do that in the past, and we've struggled really significantly getting things done across state lines because of laws and other things like that. So we really tried to put our efforts and focus into lectures like this one and the resources that our education director, Talia, has been posting in the chat, and everything you can find on our website to show family members, to show friends, to show doctors, to bring with you. That's really the best way to make the greatest impact. And we're doing everything we can on that front to help everyone.
If we look at your website, will all of those materials be there, or?
You want to say something, Talia?
Yeah, so I recognize the website can be a lot to digest and navigate, but we do have it broken down where the education section is more patient and support network geared. The provider section is more provider geared, but we have that there so you also can access things to send your providers to. But what I put in the chat box, and really the easiest way to get kind of those top resources is to visit our top resources page. We've purposely, tweezed out the highlights of the website itself, from provider guidance to the Nasaline test that Dr. Bateman was talking about, to some of the other, patient geared things like the crash survival guidebook, handouts to bring to your providers, that kind of thing. So I like to start with the top resources page. It's really the one-stop shop.
Great. Well, I think that will conclude this wonderful session, and we thank all of you, all of the speakers here, for coming and giving us your time. We're deeply appreciative.